Hello everyone and welcome to Inside Healthcare. We have a great program for you. We'll be telling you about some exciting new heart research on a medical device that's made by a Minnesota company that is being studied here in the Twin Cities and around the country that could help heart patients get off their blood thinners for good. And you will be among the first to hear about this cutting-edge national heart research. Also on this program, we learned some disturbing trends at some local emergency rooms that's putting some individuals at risk for damaging strokes or even death. So we'll begin with strokes. It's one of the leading causes of death in the country and responsible for 1 in 18 of every death. How do you best protect yourself and what are the warning signs? Well, we're very excited to have with us a group of top medical professionals who treat stroke patients. So we're very pleased to have with us Tess Zerzan. She's a clinical nurse specialist with Healthiest Neurology at St. Joseph's Hospital. And we're also joined by Dr. Eric Roth. He's an emergency room physician with Healthiest at St. John's Hospital. And then we're also pleased to have with us Dr. Paul Shanfield. He's a board-certified stroke neurologist with St. Paul. So, and Dr. Shanfield, glad to have you back with us, as well as Tess. And Dr. Roth, glad to have you back with us for the very first time. So thank you all for being with us. Very good to have be here. So let's start, Dr. Roth, first about this disturbing trend that we're seeing in some of the local emergency departments. What's happening, and do we have any idea why?
Well, most of our stroke patients at St. John's Hospital come to the emergency department by walking in or being driven in by family members. And this gets to be a problem because stroke is an important diagnosis that needs to be made as soon as possible and have the evaluation occur as soon as possible so the treatment can be started. Dr. Shanfield will talk a little bit about some of the treatment for stroke, but it's very important that it be started as early as it can be to make it as safe and effective as possible.
And this is something you hadn't seen in the past. It's a trend that has just come up recently. More so?
It does seem like there's been a trend toward fewer and fewer people using emergency services to get to the emergency department for certain things. And it's not as important for many diagnoses, but stroke is one where we have to be able to evaluate the patient as soon as possible to give them the most effective and safe treatment.
And Dr. Shanfield, I understand that you have treated some of these what so-called walk-in patients in the emergency department. How are they doing, and why is it so critical to get to the emergency department as soon as possible, and why it's not a good idea to drive yourself or a loved one to the hospital and instead of calling 911 and having an ambulance transport you there?
Yes, stroke is the only neurological problem that we know of that a potentially devastating physical deficit can be reversed by a physician. There is one FDA-approved treatment for stroke that has been approved for over 15 years, but it is time sensitive, it is time crucial. The quicker you give it from the time of the stroke, the safer and the more effective. It's quoted that 1.8 million brain cells die every minute after you have a stroke.
Wow.
Now we have billions, but
still, that sounds like an awful lot.
Some of us have more than others, and some of us use more than others, of course. The treatment is called TPA, or in English it's a clot buster, where you inject intravenously a medicine to try and break up a clot that has caused part of the brain to stop working. If you treat that quickly, you have at least a 50% chance of being better off than if you didn't get the treatment. But we can't use it if it's 3, 4, 5 hours later. 4.5 is probably the outside limit.
It's probably really changed how you're treating some of the stroke patients from when you probably first started practicing.
Yes, the ambulance trend is become more important because before 1995 we didn't have a treatment. We could do things, but nothing was proven to work. So now we actually have a treatment that's proven to work. And we even have another backup treatment that might be effective in some cases where we will actually do an angiogram like a heart study, except we'll go up and look at the vessels in the head and try to remove the clot if the intravenous clot buster, the TPA, doesn't remove the clot.
Very exciting to get that treatment as quickly as possible.
Yes.
Tess, how about who is at risk for a stroke, and what would be the warning signs or symptoms of a stroke?
Well, to your first question, we're all at risk for a stroke, but we have more risk factors or less risk factors depending on our individual situation. So for instance, as we age, I know I'm older than you are, Jody, so my risk for stroke is greater, just simply by the aging process. African Americans, because there's a greater incidence of high blood pressure, obesity, and diabetes in that population, they're at greater risk. If you have a family history, you're at greater risk. So those things we can't really control. There's also a set of controllable risk factors, and those are the ones that every one of us can do something about. So hypertension, we can all know our blood pressure, get our blood pressure under control. That's huge, not only for our brain, but for our heart and the rest of our body. That's a giant one. Getting diabetes managed well, making sure that we're on track with our blood glucoses and diet. There's a condition called atrial fibrillation, which is an irregular beating of the heart, and we can treat that, but we need to be able to diagnose it and follow and make sure the medicine is doing what it's supposed to be doing. Our lifestyle makes a difference as well. So if we're sedate, inactive people, that we believe can be a contributing factor.
So keep moving.
Keep moving, keep moving. So those are some of the risk factors, but we can do a lot of things to make a difference.
And what about the symptoms?
The symptoms, I've
brought
got
a great chart here.
yeah, poster here, and this is a good way to remember some of the major symptoms, but it's not all the ones that we want to emphasize. But FAST is a good way because it not only helps you remember the symptoms, but what you should do as well, to Dr. Roth's point. So face, look at the person's face to see if there's any drooping. Have them show you a smile. And if it's uneven, you might pick up something going on from a stroke perspective. Have the person hold their arms out in front of them, and one might be weaker and drift down, or they might not be able to raise it up. Ask them to say a phrase like Mary had a little lamb to see how clear their speech is or isn't, and then call 911. That is the best way, because then Dr. Roth and the team in the emergency departments can be notified by EMS, and we can be ready when people come to the emergency department. Dizziness, a sudden onset of dizziness, or a very, very bad headache, the worst headache of my life, many people describe it, are also symptoms of a stroke.
And does it matter where the headache is? It can be any site.
It can be anywhere, and even people that have migraines say that the headache that they have with a hemorrhagic stroke, is different, and it's the worst headache most of the time of their life.
And then also, I would think too, when you have the ambulance come to wherever you're at, you can start getting treatment right away as well, at least oxygen and things like that, right, Dr. Roth?
That's right. As soon as the EMS providers arrive, they can start to do some things that can help with the patients. I think another thing that'd be important for family members, in addition to calling 911 as soon as any of these symptoms are identified, is if they can try and account for when the symptoms started. That's going to be one of the very first questions the emergency providers ask them, both the EMS folks and us in the emergency department, because it's going to be critical for us to be able to establish a clear time of onset of stroke-like symptoms in order for us to be considering that patient for this treatment.
So what happens when they get to the emergency department?
Well, it's Health East and many systems throughout the Twin Cities and across the nation have what we call stroke programs, where we have a very coordinated effort of medical professionals that evaluate the patient very quickly. It seems like a circus sometimes when a stroke patient comes in, because we have multiple nurses in the room and ER technicians, an emergency physician, and then even some registration people trying to get the patient's name and information so we can get them registered into our system. We evaluate the patient very quickly. We ask the family and the patient some very pointed questions to try and identify exactly what the symptoms are and when they started.
Because they know their loved one better than you would at that point.
Of course, it's
yeah.
difficult for me to look at a patient and know whether their speech is slurred because I've probably never heard them speak before. But once we identify when the symptoms started and what they are, the emergency physician will usually do a quick neurologic exam that's very complete. And then we start some of our evaluation, which usually includes a head CT scan to make sure that there's no bleeding happening, some initial laboratory tests, and we'll oftentimes be able to have the neurologist, the stroke neurologist, be involved very quickly with either an in-person evaluation or even in some cases an evaluation using a sort of a robotic computer that they can do a remote evaluation if they're in the office or not immediately available in person.
And that's where you would come into the picture.
Yes, please come. Less than 1/3 of Americans today come to the ER in time to get treated. And of all strokes in America today, less than 5% are actually treated. So it's just crucial. I had the sweetest lady a few years ago who woke up and realized that she'd had a stroke, and she called a cab. All right, well, at least she called somebody. And the cab, however, took her to her hairdresser's, and she had him wait. So she did her hair, and then he had to help her back into the cab, and then she went to St. John's emergency room because she knows she had to get there, but she didn't want to look bad, you know? She wanted to look good. Oh, but please, she lost, 10, 20 million neurons in that hairdressing time.
And
So
had some
please.
permanent damage.
Yes,
Yeah.
I'm afraid.
So, and again, you were talking about some of the treatments that we have available that can really make a difference.
Yes, it's actually now called, in what Dr. Roth is talking about, it's the golden hour. There's an hour right from the beginning when you hit the door of the ER, and the quicker you get there, the better, that everything has to happen. And you have to be evaluated, you have to have a scan of the head, you have to have blood tests, you have to start this intravenous medicine treatment if you can, you have to get your blood pressure down, we have to evaluate to see if you go to the catheterization lab. All of these things have to happen really quickly. And then once this all happens, then you get to a hospital that hopefully has a stroke unit. That's a key program, that's a key advance in the last 10 years or so, that there are stroke units, because they watch very closely all the common things, but we've tended in the past to let them go, and now we don't. The sugar, the blood pressure, the fever, the clots forming in the legs, aspiration to make sure you don't get pneumonia, urinary tract infection, all those things will kill neurons if they're struggling to live after a stroke. It's really important to get to a stroke unit then.
And Tess, Dr. Roth had alluded to a little bit too that because of new technology, you don't have to go downtown to get that stroke care treatment. It is available at a lot more hospitals, even by computers.
Mm-hmm. Definitely. I mean, in Health East, Woodwinds Hospital in Woodbury, St. John's in Maplewood, and St. Joseph's in downtown St. Paul are all certified by the Joint Commission as primary stroke centers. And we're rather proud that we were the first system in Minnesota to have our hospital certified, and the first in St. Paul, in the East Metro. So we've got a lot of experience, as Dr. Shanfield mentioned. We've got a great cadre of physicians, nurses, therapists, and the whole team is very tuned into those particular needs. And then having the telestroke, the telemedicine available, I think gets the expertise of the neurologist linked in very, very quickly and remotely to a lot of people that might not already or have access to it.
Wouldn't that be wonderful if all the people that are watching get this message and they help save their loved one or themselves and from having a damaging stroke or death? And then final comments, Dr. Roth, why don't we start with you? Advice.
Sure. I would just add to the patients don't have to worry about where they're going to go if they're having stroke symptoms. If they call 911, we've coordinated with all the Twin Cities Metro EMS providers so that they'll bring them to an approved stroke center, the closest and most appropriate for them. So they don't have to think about where they're going to go. That shouldn't be what they're worried about. They should worry about calling 911 and getting to an emergency department where they can be evaluated as soon as possible.
Having to pay for the ambulance or either at that moment.
Correct. This is certainly a diagnosis where minutes matter, and we want to see the patients as soon as possible so we can get the best evaluation and treatment started for them.
Dr. Shanfield?
Well, there is a whole 1,000+ hospitals around the country called Get With The Guidelines hospitals. They participate, and they have recently reviewed their data, and they believe that for every 10 minutes that you save, you will save at least one person from having a major stroke. And every 15 minutes you delay, you'll probably have at least 5% in-hospital mortality. It's that quick. You've got to get there quick. Even though this doesn't hurt, you got to get there as quickly as possible.
And Tess, you have the final say.
I have the final say, and
course.
he just stole it. But the stroke symptoms don't hurt, but act fast. That is really the big message. Call 911 so that we can do something to save those brain cells.
Well, it really has been a pleasure to have you back with us and with us for the first time. Dr. Shanfield, Dr. Roth, and Tess, thank you very much. And hopefully this message will get out to the public at large so we can save lives. Thank you.
Great.
Thank
Appreciate
you,
it.
Jody.
Thank you.
Still ahead, you will be among the first to hear about a heart device that's currently being studied here and across the country and how it could prevent strokes. Stay with us, everyone. Thank you. Oh, no.
So this is my computer.
This is your computer. Let's go on the internet.
Let's go. Click it.
Yes.
Okay.
Eye cursor in between the R and the E. Pressing down, I want you to just push the period.
She's gonna love me all over again.
That's it. Jamaica, here you come.
Here we go.
Good job.
Alright. Thank you. Thank you. And I did it by myself. Feel smarter.
Welcome back to Inside Healthcare. Joining us now, we're very pleased to have with us Dr. Camilo Pineda. He is an interventional cardiologist with Health East. Thank you for being with us.
Oh, welcome. My pleasure.
And you recently did a procedure, some of the first procedures, using this new cardiac device or heart device that could help prevent strokes, get some patients off of blood thinners. Can you tell us all about it? Very exciting, and it's being studied here in the Twin Cities and around the country.
Correct. It's the device itself is an iteration of another device that's also currently being studied. They both are placed in the heart and occlude off what's referred to as the atrial appendage. And the atrial appendage sits off this upper chamber of the heart called the left atrium. And this atrial appendage is thought to be the source for the bulk, if not the vast majority of the clots that develop in atrial fibrillation and that can then embolize or break off and go to different parts of our body, including the brain, causing a stroke, or occlude vessels in our intestines or in our arms or legs.
And maybe you can tell us a little bit, I know a lot of people are familiar with AFib, but maybe you can tell us a little bit more about that condition and how does that perhaps lead to a stroke?
Sure. Atrial fibrillation is probably one of the most common disorders that we see in cardiology. And it can arise from a variety of reasons. Sometimes we don't know why it arises. It results in usually the heart going too fast, and that's how people recognize it. The heart feels irregular and running too fast, and they feel what's termed palpitations, where their heart feels like it's jumping around. The problem with atrial fibrillation is that in the heart muscle and actually in the tubes called veins that take the blood from the lungs back to the heart, the oxygenated blood back to the heart, those tubes seem to send off, for reasons that aren't entirely clear, extra signals that can cause the heart to race upwards 130, 140 beats per minute. And because you have hundreds of signals being fired, the upper two chambers, those atria that feed the blood down into the respective ventricles of the heart, fibrillate or quiver, and when they fibrillate like so, and they're not contracting in a normal fashion, in an even fashion, they also can allow blood to stagnate and form blood clots, such as in that left atrial appendage.
Wow, so a common treatment is there's different blood thinners, there's different medications that can help treat this.
Correct.
But they have to be on it for the rest of their life?
Correct. There are a variety of blood thinners now available, and there is a scoring system to help us figure out what is the best blood thinner to be used. I'm personally aware of this disease. My grandmother had atrial fibrillation, and unfortunately she had multiple strokes, including an embolus to her right arm, before warfarin became available. Once warfarin was, I shouldn't say became available, but became recognized as a form of therapy to prevent strokes in the setting of atrial fibrillation. And once she started that warfarin therapy and became therapeutic, that prevented further future events from happening. So it's helpful. Unfortunately, she did have multiple strokes prior to that event. So it became, for me, something to be more aware of when I work with patients, because I have that personal connection. The advance that's been made recently in the last several years to provide a device that can close off that left atrial appendage is also, I think, the next step, and I think a good idea to look into research this as an option, because as an interventional cardiologist, I put in coronary stents, and if someone comes in with a heart attack and they need to have a stent placed, then they need to be on a different type of blood thinning medicine called clopidogrel or Plavix that people may be aware of. And if they need clopidogrel plus they need warfarin for their atrial fibrillation, their bleeding risks go up much higher. So having an option for these patients a potential option to get them off warfarin in the setting of atrial fibrillation, I think can be
very
a
exciting.
plus. Yeah.
So how does, maybe you can tell us about the device, the cardiac plug. How does it work? How does it prevent these strokes?
Sure.
Or clots?
And first and foremost, I want to say that both devices are in clinical trials right now. So they are not, you can't just ask your cardiologist to put one in. And those clinical trials have certain criteria in order to get into the trial. But if you fit those criteria, then you could be enrolled in and potentially get one of the two devices. The devices are placed, it's not by surgery, it's done via procedure, meaning that you don't have an incision made on your chest wall. It's done through a vein in the leg, and a tube is placed up and placed into that left atrial appendage, and then a device is pushed through the tube and deployed in that left atrial appendage. And you then release the device and then take the tube out, and the vein is then sealed up or pressure is held there at the site. People are watched overnight, and if everything goes well the next day, they're released home. They have a follow-up ultrasound in 4 to 6 weeks after that point. And then if the device is well seated and there's no evidence of leaking around the device, then their anticoagulation is stopped, and they're followed then per the protocol. And then again, there are 2 different trials, so 2 different protocols. Again, from a patient perspective, they're excited about it because if they have an opportunity to get off warfarin, that's a big plus. There are good and bad with everything we prescribe in medicine. There's never a free lunch,
Magic.
so to speak. Yeah. With the device placement, there are risks to putting it in. And being on long-term anticoagulation, there's risks of bleeding. And so we have to weigh the risks and benefits of either of these. And in order to understand what those risks are, that's why we do these clinical trials, to compare the two. So it's very important that we complete these trials so people can know what's their best option.
And I understand that you and Dr. Stuart Adler have done the first 2 patients in the Twin Cities with this device. Probably too early to tell how they're doing, but how generally are they doing? Do we know yet?
Well, we have Dr. Adler and I. Dr. Adler actually worked with the first device called the Watchman device by Boston Scientific, and that earlier trial, randomized trial that was done. We are now performing we have access to the Amplatzer device made by St. Jude, and they're doing a randomized trial, as well as the device provided by Boston Scientific in a third trial down the road that they're working on. So we're excited to participate with both of these companies to provide access to. Yes, and answer your question, with the Amplatzer device, we deployed two about a month ago, and they both did fine. There were no complications with deployment. They're now in the process of getting their ultrasounds to see if the device is sealed off, that left atrial appendage, and to be certain that they can come off their anticoagulation.
So if everything is okay, then they just follow up with you every so often, or I mean, how do it's cured? It's corrected?
If
I know
if
it's
the
in
clinical
trials,
trial
so-
comes out and it shows that this device or the other device is equivalent to medication, then it goes back to the FDA, and the FDA will make a judgment as to whether or not the device would be released, and that takes some time too for them to make the proper judgment. Then once we have access to it, that's where physicians use their judgment as to follow-up, and there can be some variation as to follow-up and how it's done and what kind of studies are done for follow-up. But as part of the protocol, patients are followed in the study, as I mentioned, at 6 weeks for this one trial. They get an ultrasound, and then they're followed on a regular basis every, I think, 2 to 3 months. They're being contacted, and they come back and visit us, I believe, at 6 months and a year. We have a neurologist who is also working with us with this trial because the concern is stroke, paramount, and being able to track any symptoms that may imply there's a stroke is very important.
Wow, it has to be very exciting to be able to potentially offer your patients some options like this.
Oh, yeah, we're really excited. I think more importantly, we're excited to get this answer. It's I think part of the care that one of the many reasons I really enjoy working at Health East is active participation in research trials and wanting to be able to be a part of building upon therapeutics and medicine, and being able to make things work better for the people we're trying to help.
Well, I keep thinking how different it would have been maybe for your grandmother as well, and people like her.
Yeah, that's a great point. I mean, just had they done the trial earlier to show a benefit of warfarin back in the 70s, then she wouldn't have had the strokes that she had, but
and I know
it's
this
medicine.
is one of a number of heart researches that are currently going on at Health East Heart Care. So, and final comments about this heart device, if someone is interested, if they are a potential candidate, how do they go about finding out more about it?
If they're interested in participating in this trial, the first thing is to contact the Health East Heart Care research line, and we can make that available.
We'll put it on the screen.
The advantage behind this is contacting them directly. They will review your history and see if you would be a candidate to be able to participate in this trial.
And they have to fit that criteria.
Correct.
Exactly.
Correct.
Any final comments about the heart research?
I think we're a newer organization with Health East in the last 2.5 years, but it's been exciting to participate with the Health East team. They've really grown by leaps and bounds. And again, the bottom line is we're here for the community and try to be able to serve a niche for the community. And happy to be here. Thanks for taking time out and inviting us.
Oh, it's been such a pleasure to have you with us. So thank you so much for taking time out to be with us.
Sure.
And to share this information with our viewers.
My pleasure.
Very exciting news. So thank you, Dr. Pineda. Thank you so much.
Sure.